Good afternoon, everyone, and welcome to the COVID-19 Solutions in Long-Term Care Communities, Regaining Control to Keep Your Seniors Safe webinar, sponsored by Enviral Tech and hosted by the Washington Healthcare Association. I'm Jennifer Summers, WHCA's Assistant Director of Member Services. A few housekeeping rules for today. This webinar will be recorded. Should you have any questions, please type them in that Q&A box and we will address them at the end of the presentation. If there's any technical difficulties, let us know by using the chat box. CEU instructions and how to obtain your certificate for today's webinar will be sent out by the end of the week. With that, please help me in welcoming Yuan Clovis, Sales and Marketing Operation for today's sponsor, Enviral Tech. Welcome, Yuan, and thank you, Enviral Tech, for this afternoon's webinar.
Thank you, Jennifer. Hi, everybody. Thank you for joining us today. We have a great talk for you and a great result from the skilled nursing and long-term care facility study that we have done, and we're very excited to share that with you. So today's speakers are three. We're going to start with Phil Fogg, Jr., who is the CEO and President of Marquis Companies. So just a quick introduction to Phil. After graduating with a degree in healthcare administration and an MBA, Phil Fogg formally entered the senior care profession as an administrator before stepping out on his own. And he started Marquis Companies in 1989 and assumed the management of his first skilled nursing facility then. Throughout his career, Phil has been a respectful and influential advocate for long-term care in Oregon and across the nation. And he's credited with helping elevate the profession by championing resident care outcomes, increased reimbursement, workforce initiative, and strategies that help navigate the profession through challenging times. So please allow me to welcome Phil. And Phil, the mic is yours.
Great. Well, thank you very much. I don't need to tell anyone on this call that when we started this pandemic outbreak, our worlds have changed in amazing and mostly negative ways. Who could have imagined that somebody or something happened that was going to target the very population of people that we serve? And again, I just start this by acknowledging this has been a very difficult and challenging time for our profession. And, you know, it's likely to continue until we see a vaccine. I know we'll get through it, but it certainly has created unique challenges. Today, we're going to talk about testing, but before we do that, I want to hit some of the numbers. And this is very early in the process, but there's things that we're starting to learn about COVID-19. Before I do that, you need to know there's about 15,500 skilled nursing facilities, 42,000 assisted living facilities, or about 57,500 what I call long-term care, post-acute care facilities. When you now take those numbers and you look at the number of facilities with known cases, so we've got 9,822, or about 17% of the facilities in America have had some positive COVID residents. There have been 240,000 positive cases within long-term post-acute care facilities and 50,000 resident deaths. That results in about 45% of the deaths in a state are related to long-term care PAC facilities. And obviously that's a disturbing number, and I'll talk to you about that a little bit more. And then again, the LTC PAC facilities cases are about 14% of the overall cases. So the deaths were about 45%, of the overall cases were about 14. And I give you all these numbers. I took them from the Kaiser Family Foundation. And I just want to acknowledge throughout this today, you know, we're so early in this process that, you know, you do the best you can to get numbers, but I think we all recognize that there's challenges with the validity of some of these. I only threw this on. You can get a sense for the hot spots in terms of the confirmed cases by percentage of deaths by state. And you can see that the East Coast has certainly been hit more dramatically than the West or the Midwest. So let's talk about some early research. This is information today that I'm bringing from David Grabowski, who's a PhD at Harvard. American Healthcare Association was involved with gathering some of this research. But one of the things we know is that the quality rating for a facility was not a factor or correlated to COVID-19 outbreaks. You could be a 5-star facility and it didn't change the probability that you would have an outbreak or not. There was no significant differences between for-profits and not-for-profits, which was interesting. And I think we all now know that it's the asymptomatic spread and lack of testing availability that was really the thing that I think has got this thing going in the beginning. But the asymptomatic spread is what makes this virus so dangerous to our environments. And then what you, again, all probably know by now is that the preliminary research is demonstrating that the facility outbreak percentages or number of cases are directly related to the community outbreak cases. And I think that the key thing that we try to reinforce with our buildings right now is with the restrictions on visitations. If we're going to have COVID-19 come into a facility, it is going to be through our staff who have got it into the community. And so that is the primary principal danger that we've got. Some further information, and when you look at why is our population so at risk, and look at these numbers, 2/3 of the U.S. deaths related to COVID-19 have been people over the age of 75. So separate of long-term care PAC environments, 2/3 of the overall deaths have been with people over the age of 75. The majority of those have had 2 or more chronic diseases. And again, that's our population of people that we're serving. We probably average 3 to 6 chronic diseases or comorbidities. And our population has weakened immune systems, respiratory conditions, or underlying cardiovascular conditions that expose them to being at risk, not just for the virus, but for death. And I think one of the things that hasn't been probably clearly communicated in the media as we've been going through this outbreak is not only is the population we serve at risk, but we also serve a population of people that have done a lot of advanced care planning. They may have pulse documents in place. So when we look at these death rates, we're talking about a population of people who have made choices to not be resuscitated in the event that they stop breathing or don't have a pulse, to not go to the hospital. And so this has also had a contributory effect on death rates. So I'm not making an excuse, but I just think there needs to be an awareness of this issue. So I'll get to the testing side, and I just would say I was particularly intrigued when we started framing internally what we were going to react, what our plan was going to be. I saw a great article by Atul Gawande that's referenced at the bottom of this slide, and we've kind of built our strategic plan for fighting COVID-19 around this. I want to acknowledge that you have to have all 6 of these elements to really have an effective defense or have any chance. But I'm going to highlight testing for the moment and just tell you very quickly that I think, again, for all of us, it's been a journey. And we've slowly been picking things up and getting information and knowledge and sharing it. And but one of the main things that we've done as an organization, and I know several other Northwest providers are doing, is we've gone to using surface testing as a lead indicator of COVID-19. It's not necessarily conclusive, but I will say that we've had 2 facilities that we've had outbreaks in or positive cases. Both of those facilities had positive surface tests. And so I can tell you that in our small population or small sample size, we got positive surface tests when we had confirmed positive cases. So we as an organization have gone to using surface testing as a lead indicator of, hey, you might have an issue. When we get a positive surface test, we are now going to test 100% of the staff. Now, there's a few situational things that may or may not affect our resident testing, but I would generally say we're going to do 100% testing of the staff and 100% testing of the resident population, because we've learned by experience, there's risk when you do 100% testing, but it's better to know the extent of your problem early than to know it later. And I would say, again, that's why that surface testing to us is critical, is If we can get 2 weeks of lead time as the asymptomatic spread may occur, those are very, very valuable 2 weeks for us. It enables us to do staffing planning, and it enables us to look at PPE supplies. It influences a number of things. Even if it's 3 or 4 days, it can be very impactful to our response. As it relates to testing, many of our states are creating their own requirements for reopening. I would tell you that no matter what the requirement is, for example, Nevada went to just one baseline test for residents and staff, but we are going to just continue to test 25% of our staff every week, so that every month we're getting 100% testing. It just makes us feel better to do that. And then again, our resident testing protocols are based on what we find out of our staff testing results. And again, everybody on this call knows how many different scenarios and situations could influence that. And the last thing I just would address with testing is just there is a bit of a disconnect in some of the states that you just have to be aware of. I realize that testing protocols sometimes could be limited, unfortunately, when you might get a state or a federal mandate, and yet there may not be the dollars there to support it. And I'm very sensitive to the economics of different states and different providers. But I can tell you from practical experience that if you get an outbreak, you will wish you had spared no cost on the testing expenses. It is just takes a toll on an organization, whether you're one facility or multi-facility organization. It impacts people physically, emotionally, and it is a very hard process. And again, I'm just going to reiterate, I would do everything you can to invest in this testing. It is better than the alternative. So with that, I'll hand it off to the next presenter.
Thank you, Bill. That was great. So our next presenter is Kevin van den Wymelenberg. And so Kevin is a professor of architecture at the University of Oregon, and he has a PhD in the built environment. Kevin founded the Institute for Health in the Built Environment and directs biology and the Built Environment Center here in Eugene. His work seeks to broaden the network of researchers and practitioners such that issues concerning health, comfort, and sustainability in the human ecosystem are addressed in a way that benefits our work, our community, and our planet. So thank you for being here, Kevin, and the mic is yours.
Thank you very much. Really excited to be a part of this project or this discussion. I want to first and importantly give credit where it's due. A lot of the work that I'm going to talk about today is certainly not just me. We have an incredible team here at the Institute for Health in the Built Environment and the Biology and the Built Environment Center at University of Oregon. In particular, I'd like to give shout out to Leslie Dietz and Patrick Horv, front and center there in the blue sweater and green plaid shirt for their heroic, I'll say heroic efforts in a lot of the research that I'll be presenting now. But the whole team really, because the work that I'm presenting casts an arc of over a decade of work on microbes in buildings. Before I jump in, I just wanted to share a little bit more about who we are. We're multiple labs within the University of Oregon working together in the Institute, but the Institute also represents multiple partners at several research institutions across the country and industry engaged professionals from around the world, as depicted here in this image. So microbes everywhere. We are made up of trillions of microbes. Our gut microbes regulate our digestion and can impact our mood and our weight. Our skin microbes can have immunoprotective effects. About 5 kilograms of us is not human. It's microbial life. By cell count, we're more non-human than we are human. And humans comprise about 70 trillion cells. We eat about 20 billion bacterial cells every day. We inhale about 3 billion and we drink another 40 million. And of course, we also exhale and cough and sneeze. Everything from our skin and gut to the Mars rover are covered in a diverse microbial ecosystem. Buildings house trillions of microorganisms reacting with each other, with humans and their environment. The indoor microbial landscape may be in or out of sync with our personal microbial communities, and when they're out of sync, this mismatch may pose health risks. Importantly, understanding microbes is a design opportunity microbes in the indoor environment is an opportunity to support human health in unprecedented ways. So this is a visualization of the Lillis Business Complex here on the campus at University of Oregon. And what we're seeing here is just kind of a sense of the geometry of the space, but we have done extensive microbial sampling around this building, and papers were published on this. This project started almost a decade ago, and papers were published 7 or 8 years ago. What we did was we sampled surfaces within this building to understand the microbial community structure. And so you can see here, we were focused on bacteria, but we were looking at creating these surface maps or heat maps or spider plots of the bacterial community structure, which classes of bacteria were most prevalent in this case in offices. We also studied other space types, classrooms and restrooms. And what we noticed there was that each of those space types had a unique microbial signature. Here you can see the shape of that plot is much different in a restroom. And so we know that this has something to do with the architecture as well as something to do with the human activity. And, you know, of course, we are architects and engineers, and we're really intrigued with the ability for engineering controls to shift that indoor microbial community structure. And what you're seeing here is a 3-day study where on Friday evening, we shut the ventilation system off, and we saw the rise of the microbial abundance in those indoor spaces. And that's contrasted with this, where we did natural ventilation on Friday evening to flush microbes out of the building. And while we do see a rise in the abundance, if you look at the shape of those spider plots, you'll see that the community structure shifted such that it was much more outdoor associated microbes and fewer human associated microbes. And by extension, therefore, lower likelihood of potential human pathogens. So these are the methods that we use. We use surface swabs, passive air settling dishes, which do a short-term time integrated sample of dust that might, or microbes that might settle out of the air. And then we also do active air sampling with liquid impingers. And we've done several different versions of active air sampling. All 3 of these techniques have been validated and proven to be very effective at collecting specimens from our buildings. Once we have those specimens, we will process them using a quantitative reverse transcriptase polymerase chain reaction. And I'll just have to say, look, I'm an architect and I'm just so glad that I could actually get those words out. It's a mouthful, but really the takeaway here is that these are reliable, sensitive techniques. They're really the gold standard. They're research grade, and there's guidance from the World Health Organization as well as the Center for Disease Control about these methods. It's what we're doing in our research, and it's what we're seeing other people publish. Okay, so a little bit of a pivot here. We're going to talk a little bit about the coronavirus. And you know there's a lot of evidence around human to human and droplet, but we're learning more and more about aerosols. And this image here just gives you a sense of the potential of aerosols, these ultrafine particles that remain in the air, and you know, here can be demonstrated as reflecting in the sunlight. Here, a different form of light is exploring that same concept. This was a much more recent study from Japan looking at ultrafine particles that remain aerosolized for long periods of time, as much as hours, as many hours. And pairing that with other data, we know that those ultrafine particles do have the potential for holding viable coronavirus. In fact, more research is coming out daily, so it's an area of active reading for me. And so how does that connect to the virus and the built environment? And so what I'm showing here is a visualization that we put together related to the restaurant in China that got a lot of press in late March, early April. You may have seen these. They were picked up by CBS and BBC for news stories. And it really was a way to try to make this invisible visible. And what you see here are these aerosols of different sizes and colors. The colors represent droplets of different sizes and how they may be dispersed around a room. And this is showing the impact of architectural considerations changing that dispersal and engineering controls. But really the take-home message, I think, for today is that those aerosols do eventually find their way onto surfaces and are therefore indicative of what the exposure might be in our built environment. So jump to our pilot study with Oregon Health and Sciences University. As soon as the pandemic hit our shores, we resumed our relationship. We had already been studying pathogens for hospital-associated infection with our partners at OHSU. And this just shows the plans for 2 wards at OHSU where we were doing sampling. And I'm just going to give you some really high-level findings. And first, I want to say thank you for OHSU for their willingness to allow me to share these results. As you can imagine, it's incredibly sensitive information, but at the same time, it's so important for the preservation of human health, of staff, and of patients in healthcare facilities. And really, OHSU is showing their leadership, in my opinion, by allowing me to talk about this. They routinely exceed safety standards, and these kind of tests are helping them maintain that edge and keep their buildings as safe as possible. So what you're seeing here is a neutral pressure patient room, and the black circles that are empty represent negative swab locations. The black circles with a red infill are representing a positive swab location, and the red circles that are with no fill is a negative settling plate or petri dish, and then the red circles with a positive fill, which there are none of on this slide, are the positive petri dish settling plates. And then the last thing to notice here is this red box is where the supply air comes, and the blue box is where the room is exhausting that air out. And what we were able to see here is that that room location, it is a surface sample, but that exhaust location was a tested positive in the bathroom floor. What's interesting here, and I think lends credibility to the sensitivity of this process, is that these were empty rooms. They were cleaned, and they had no COVID patient in them, in this case, ever, and no COVID patient on that ward in 11 days prior to the sampling. This is the negative pressure isolation room that had seen COVID patients, but not for 11 days, and again, empty and clean when we sampled it. These rooms take air from the whole ward and evacuate it out of these rooms so as to minimize the potential transmission out of the room back to the ward. And you can see, perhaps not surprisingly, given the context, that there are some more positive locations, and here, interestingly, a positive petri dish location as well. And then I want to just show this really quickly. An operating room, you know, kind of the best of the best, high efficiency filtration, high air change rate, low occupant density, and again, no positive COVID patient had ever been in this room. And we did find some probably relic RNA in the corner on a settling plate, which gave us some clues about how we could continue to study the building. So why test buildings? The image on the right is of the call center in Korea, again, published late March, early April, and it showed an attack rate of 45% on the floor. So almost half the people tested positive upon subsequent contact tracing. The image on the left is this concept that we could test buildings and implement controls to mitigate potential outbreaks or at least reduce the spikes through engineering controls, deep cleaning, and also focused human contact tracing and testing. And here's really where it hits the road, where the rubber meets the road. We can see in this call center on February 22nd was the first time someone showed up with symptoms. So chances are the 3 days prior to that, they were pre-symptomatic, shedding virus into that space. If we had found the virus in that space on February 19th, 20th, or 21st, it's quite possible we could have minimized that outbreak a week later. And if that was too few virons to be detected, which is possible, I have high degree of confidence that we would have seen this spike and been able to at least take the edge off, because these people would have been shedding virus into the space as early as February 24, 25, 26. And I think we could have retrospectively shaved or eliminated that spike. So now what? You have this information. The good news is there are engineering controls, practices, policies, procedures, PPE, et cetera, that can be triggered to help minimize outbreaks and give feedback through repeated testing about the effectiveness of these engineering strategies. This is a paper we authored in early March about ways to reduce the risk of viral transmission indoors. So I just want to end with that and say, both lives and livelihoods matter. We have to find our way to work through this problem and live through this problem. It's really about trying to understand how to operate buildings on a new frontier, and I'll say that a new frontier needs new pioneers. Thank you. I'm going to turn this over to our next presenter.
Thank you so much, Kevin. That was great data. I actually had not seen it before and so compelling. So our next speaker, last speaker of the day, is Steve Turner, and the CEO of Enviral Tech. So Dr. Turner founded the Pacific Biosciences company and then served as a CEO until 2004. Presently serves as CTO. He was awarded a PhD in physics by Cornell University in 2000 and was a member of the team that invented SMRT sequencing. Dr. Turner's undergraduate work was at the University of Wisconsin-Madison, where he received a BS in applied mathematics, electrical engineering, and physics. And so Stephen is the author of over 50 scientific papers in fields ranging from DNA sequencing technology and biophysics to genomics and epigenomics. He holds over 100 US patents. So Steve, welcome, and thank you for joining us. The mic is yours.
Thank you very much, Joanne. So this pandemic, the perspective from a scientist is quite different, I'm sure, from a long-term care facility operator. From our perspective, it was pretty frustrating to be sitting with technology in our hands that we knew could save lives and seeing it not available to the people who need it the most. So at the beginning of March, we started a company, a group of us that includes Shula Jaron, Matt Baudet, Brian Patch, myself, and others, including Joanne, started Enviral Tech specifically for the purpose of making these state-of-the-art technologies available to the people that need them the most in this time of pandemic. We've got 60 years of combined experience in detection technology development. We're located in Eugene, Oregon, and as I said already, we put this company together specifically to ally ourselves with those that need our help the most. So we are focusing on at-risk communities. That means the long-term care, senior care communities, the people that serve the most vulnerable populations. I'm going to skip quickly through this in the interest of time, but there is a point here. The technologies that we're using, we did not invent these. These are, as Kevin mentioned, these are techniques that have been around for more than a decade. They're recognized by CDC and WHO as important adjuncts to human testing, the surface testing, and the tests themselves that we're using are FDA emergency use authorized tests, though we're using them in a non-human testing setting. That means that when we do a surface test, we are not depriving anybody of a human test because we know how important those things are. We built a special purpose-built laboratory for this purpose. So the service that we offer, the product and the service, includes a kit that contains the swabs that you need for swabbing surfaces, as well as the the vials that contain the special preservative medium, the shipping envelope to bring it back to the lab, back to our lab, and we provide both a results summary that clearly shows the user what's happening inside their facility, as well as a certificate that our customers are free to post if they wish to, certifying that their facilities are free of the COVID-19 virus. So we set out in collaboration between ourselves, 3 different long-term care companies, the University of Oregon with Kevin's lab, as well as others, including certified industrial hygienists, to put together a large study. It's actually the largest of its kind, in order to answer a series of questions about how surface testing could help us. Specifically, can we save lives with early warning of COVID-19 from surface testing? Can we provide employees and residents assurance and well-being from that sense of confidence? And where and how many samples and how often should we sample these facilities in order to most cost effectively provide protection? So the method that we converged on was to test 8 surfaces each in 2 times a week in over 50 facilities for 21 days. And what we wanted to look for was to measure the prevalence of COVID-19 in these senior care communities, to look for the accuracy in order to study how these surface tests perform in a real world setting, and then to observe the impact that that surface testing has on COVID-19 containment efforts. The study parameters, we recruited 3 companies. We, in the end, ended up with 52 facilities. There were a total of 625 surfaces that were nominated, and on those 625 surfaces, a total of 2,605 individual swabs were gathered over a period of 5 weeks. In the facility, the staff would unpack the kit. Each swab would be rubbed against the surface that they had chosen. They would insert that swab into a vial that contains a special preservative, put it in, give a secondary containment in a bag, put the bag in a box, and FedEx it to us. Now, this is important for understanding the results that I'll show you in a little bit. When we unpack that in our biosafety laboratory in Eugene, Oregon, the first stage is that each kit, which consists of 4 vials and 4 swabs, we would pool those together into a single tube and run that through the gold standard ultra-sensitive RT-PCR that will tell us whether there's any COVID-19 in that pool. So by doing this, we can save some resources on the expensive testing. And if the pool is negative, then we would immediately report that all 4 of those swabs, if the pool is negative, all 4 of the swabs must be negative. If we got a positive or an inconclusive answer, meaning something that was too close to the borderline to know for sure, we would then test each of those vials separately and report back on the individual swabs which ones were positive according to the information that the customer provided us on the card at the time they filled out the swab. So you'll see the data from the test in a little moment, but first I want to talk to you about what surfaces were chosen. We gave some guidance to the facilities based on input that was published from the World Health Organization and the Centers for Disease Control about what kinds of surfaces would be best to select, but we left the selection of those surfaces up to the facilities themselves. And this is just showing how many surfaces were selected from each. Popular examples were doorknobs, desks and counters. We had time clocks, appliances, faucets, office furniture, as well as some cases where we didn't know. Category unknown means that we did not receive information about what the identity of the surface was. And I'm going to come back in a little bit to show how the positive tests assorted themselves across these different surfaces. We had 3 different types of facilities in the study. We had community-based care, skilled nursing facilities, and memory care. The majority were community-based care facilities, 389 surfaces there, 220 in skilled nursing facilities, and only 16 in memory care facilities. But we did get positive results in each of these different categories. Now, before I go into the study data, I want to make sure that I'm being clear that what the customer would see is very simple. It's an easy to understand, easy to read report. Here I've anonymized a report that actually came from the study that shows in each case which group of 4 surfaces was tested and the fact that it had come out negative. There's a second page to it that has a glossary that includes all the explanation of terms, and the reports are cumulative, so they get to see the entire history of their facility on each report that they get. And I'm showing this because I'm about to dive into a much bigger data set that necessarily has to be a little bit more complicated, but I want to make sure that you understand that that's for this study, not for what the customer sees. The study data we look at like this. This is a tableau where you see from left to right is time, each day being represented by 2 columns. It's 2 columns because we have pooled data and we have individual swab data. You can see they're in clusters of 4 most of the time. There are some exceptions where if the facility changed the grouping of the surfaces during the study, then obviously we have to follow that in the way that we present it. But usually they're in groups of 4, and you can see where if there was a negative pool, that we would not follow up with a test on the swab, whereas if there was a positive pool or an inconclusive pool, we would retest it and then show which of the swabs could have been contributing. We don't have to worry too much about these letter codes. The color shows you everything you need to know. Green means no virus. Gray means no test because it wasn't needed. Yellow means inconclusive. That could be either because it was too close to the borderline or because some of the internal controls that we have in place to make sure that the test is working indicated that there were problems. Blue would be borderline, meaning that there is evidence of virus, but very close to the borderline. And then positive, low, medium, and high would mean that there is a strong and reproducible signal. Each row corresponds to a different surface in this case. And now I'm going to move forward and you'll see just how much data we took as we expand out. But first, let me summarize the results. As I mentioned, there were 52 facilities tested. 18 of those showed positive COVID-19 surfaces. So that means 1 or more surface tested positive for COVID-19. That's a rate of 35%. Of the 625 surfaces, 55% of them tested positive. So that's 8.4%. And of the total swabs, the 2,605, 64 swabs came up positive, or just about 2.5%. The entire data set is too big to view. This is showing the entire tableau of every one of the 52 facilities along the left axis and the time across the top. But just to give you an idea, I do want to step through and show you the entire data. We've anonymized the names of the facilities and given them a random-ish number at the side to identify them in order to preserve their confidentiality and their privacy. But you can see most of the surfaces came back negative with occasional positives. And I'm just going to step through to show you the magnitude of the data that we took. This is the largest study of its kind, possibly the largest surface sampling study for viruses anywhere, with 2,600 swabs. And I'm just going to click through to give you an idea just of the scale of the data that we took. Now, what were the results? The first thing is what kinds of surfaces produced positives on COVID-19. Now, here I've ranked the surfaces according to what fraction of the swabs came back positive. This dotted line is that study average of just about 2.5%. The big winners were chairs, carts, faucets, laundry, copier. Now, there were many different numbers that were included. So there were too few faucets to be certain that this was statistically significant. It was borderline. Likewise with the chairs, they were showing almost twice the rate with a statistical significance that was almost to the point where you'd believe it. the big surprise for us was carts. This included nursing carts, food serving carts, any kind of a mobile cart on wheels. There were enough of those in the study that we're sure that those were overrepresented. That's more than 2 times the expected rate. And that was a big surprise to us. Another big surprise was air vents, which most other studies on COVID-19 have shown an association between the virus and air vents. We did not see any. This result is not showing statistical significance because we didn't have quite enough air vents in the study to know for sure. But given how much more often they appeared in other studies, we were surprised by that, and that's something that we're still looking into. Now, another important aspect of this study is to figure out how accurate are the results. And there are sort of 3 levels of accuracy. The first one is testing it in the lab using standard materials that we would get through either clinically validated labs or from the CDC that offers positive controls. And in those tests, we get false positives less than 0.1% of the time and a sensitivity greater than 95%. That means that out of 20 known positive samples that you'd get at least 19 of them. And the false positive rate means that out of 1,000 known negative samples that you might get 1 false positive. But that's in a situation where you're shooting fish in a barrel, so to speak. You've put those samples in there in the wild, so to speak. When you're going into a facility where you don't know whether there's material there or not, we want to know how it performs there. And it's difficult because there's no gold standard here to compare with. We're actually using the testing methodology that's considered the gold standard. So we have to rely on other methods. Our study design that I showed you before has a retesting component. That gives us the ability to use internal concordance to put a bound on the false negatives and false positives. What I mean is that if we get a positive pool, we retest that information by swab, and that allows us to see whether the results are consistent or inconsistent. Now, in the study with all over 2,600 swabs, there were exactly 3 inconsistencies where we had the pool test positive, but not one of the 4 swabs when we checked later showed up positive. Now, that gives us an opportunity to put bounds. We can't know for sure which of these 2 was right and which one was wrong. But if we think about worst case scenarios, if we imagine that all 3 of these positives were false positives and that in fact the swabs were all negative, well, that would correspond to 3 false positives out of 598 pools that should have read negative. That's about a 0.5% false positive rate, which is pretty good. Correspondingly, if we assume that all 3 of these pooled results were correct and that 1 or more of these swab tests falsely produced a negative, well, then that would mean between 3 and 12 false negative swabs out of a total of 76 that either were positive or should have shown up positive. That's between a 4 and 15% false negative rate. Just for comparison, the human testing that we all rely on has between a 20 and 30% false negative rate. You'll sometimes hear it described as a 70% sensitivity. So that means that we're doing pretty well. We're as good or better than the human testing in terms of our sensitivity and our specificity, the false negative and false positive rates. Now, there's another aspect of this. What I just described was when we're talking about if there's virus in that little tube that we provide, that the test will show that there's virus. But there's another way of thinking about it, which is how good are surfaces at reporting on a facility? Because, you know, in Kevin's video before, it showed that the distribution of microbial life was essentially everywhere. But there was another video where you saw the sneeze in the restaurant where maybe a smaller fraction of the surfaces got contaminated by the COVID-19 in that case. So another very important part that we got from the study was indication that in a contaminated facility, that each surface that you choose has about a 25% chance of showing virus. Now that means that if we assume that those are random and independent, that means if you were to swab 4 surfaces, you'd have about a 70% chance of detecting an outbreak. And if you chose 8, that those would climb up to 90% chance of detecting an outbreak in a facility. We observed at the beginning the 3 different kinds of studies. We have an opportunity to look at how those positives are distributed across the data set. We can see that with a total of 56 positive cases out of the 625 surfaces that you would expect to see out of 389 in community-based care, we should have seen about 35. With 16, we would have gotten just maybe between 1 or 2. And that in the case of skilled nursing, with 220 surfaces, we should have seen about 20. And what we actually got was significantly fewer for the community-based care, significantly more for the skilled nursing, and we got quite a bit more for memory care, but because of the small number of surfaces, we're not sure that this is statistically significant. This makes sense probably because the skilled nursing facilities tend to have a larger staff to resident ratio, and with staff being the principal route of entry of COVID-19 into these facilities, it probably makes sense that you'd see this overrepresentation in the skilled nursing facilities. Now, a very important aspect of this is to coordinate what we saw on the surfaces with what the human testing for those facilities is reporting. Now, I have to put an asterisk on this because we're still in the process. The study just concluded a few days ago. In fact, we still have data trickling in now, but we took a survey a week into the study about how many human tests had come back positive. So at that time, we had a concordance level where 26 facilities had 0 positive COVID-19 cases in humans and also showed 0 positive surfaces. We had 12 facilities that had 1 or more positive human case in either a resident or an employee, and also had 1 or more surface tests. Now, we did have 6 where there was no human positive, but we did see a surface positive swab come out. Now, we know that we still have data coming in, so it is possible. In fact, I learned just a moment ago that of an additional outbreak from Phil's presentation, so that we can increase this number from 2 to 3. That we had outbreaks occurred during the study. That means that we would not yet be counting them in the correct column. So this number is likely to go down, and this number will go up. But we did have 2 known outbreaks during the study. Now, we also saw cases where we did not see any contaminated surfaces, but there were 1 or more humans that tested positive. In this case, we know for a fact that some of these were employees that got sick, got tested, and stayed home, meaning they never entered the facility. So there would be some portion of the time where the facility shouldn't have been contaminated because they never got, the employee never went to the facility. We also know that some of those cases resolved before the beginning of the study. And we also have to consider that the cleaning protocols that are in place are focused on exactly the same high-touch surfaces that we were sampling. So this could be an indication of successful cleaning protocols in some of those cases. We can look at also the numbers of sick patients and the numbers of positive swabs. And we see that a very strong correlation. There are, as we said before, 26 cases right here in this corner underneath that dot, and the rest of them distributed to upwards of 80 people testing positive in a single facility. And you can see that there is a strong correlation between how many swabs test positive and how many people test positive, and an extremely high statistical significance. So we're quite sure that this result is real. We also, as I mentioned, that there were 2 facilities that we actually caught during the 3-week study, and I'm showing you there in their anonymized code, facility 185 and 142. You can see everything is going along with every surface coming back clean until suddenly on the 2nd of June, we see strong evidence of the appearance of COVID-19 in that facility. And you'll hear from the clinical director of that company about how that person was asymptomatic and did not show any symptoms until days later. Now, we had another case, facility 142, where an employee had developed symptoms and submitted a sample for a human test. And in this case, the surface test showing the positive surfaces and the human test, those results came on the same day. So we didn't provide advance warning, but it was certainly confirmatory that that employee had shed virus into the building and had not managed to stay out of the facility before having that test. And then with that, I want to show you in their own words, describing their experience and those two outbreaks, the experience of those two companies.
So we started the surface testing study within Marquis beginning of, I think it was middle of May, for the study. And it was interesting. We weren't sure. We were kind of reserved in what we thought this would show us. And so we did 4 facilities in the study for 3 weeks.
Our experience with using surface testing in our communities has been certainly a learning process, but what we were really impressed by was how easy it was to pick up on it.
So working with Enviral Tech, it's been very smooth. I think Shula's our main contact person. She's really good at getting the test results back to us, letting us know if something's missing. She's very quick at responding back to the facilities.
The employees that we had the opportunity to work with from Enviral Tech, Shula and Sadie and others, were absolutely remarkable in that their responsiveness, their willingness to go above and beyond to make sure that we had results timely, sometimes receiving results in the middle of the night. The feedback we received from employees, residents, and families, for that matter, has been very positive. I think anytime you're actively looking for the virus and trying to detect it and keep them safe, that provides confidence. And from a workplace standpoint, we want to make sure that our employees know that we're doing everything we can to make sure that the place that they come to work is COVID-free and they can remain safe and healthy so that they can confidently serve our residents. So it's been very positive.
You know, my part being skeptical, I'm like, well, if I only swabbed X surfaces, I didn't swab a zillion other surfaces. So what's it really going to tell me? What's the value of only doing, you know, you can do between 4 and 8 swabs. We've chosen to do 8. Thinking I didn't get that handrail, if I didn't get that bedside, I'm going to miss it. But I think it's that what was surprising is how well it did. When you've identified those key high touch points in your facility, how sensitive it is and how well it did at catching that, and also how easy it is. The testing itself is very, very easy. And to be honest, the reports we get back from Enviral are very easy to read. They're simple, they're easy, and you can see exactly what's going on.
You know, everyone mailed the test kits in, very smooth process, as I said, but you know, ultimately what was most valuable to us was when we got our first positive. We found it on an employee time clock where they clock in. So we knew that somebody on the staff had it. And so that allowed us to immediately human test all of our staff who work in that building. And we were able to find the positive staff member. And, you know, that early detection, because they were completely asymptomatic, that early detection, that bought us at least a week's worth of time because that individual didn't develop any symptoms for days afterwards. So imagine how devastating that could have been. So we're big believers in the positive effects of using the kits and how they can really shape your detection and your fight against COVID to really search for it in your community, find it early, and then get rid of it.
We ended up with one of our facilities at the end of the study period who ended up in a large outbreak. About the same time that we identified the outbreak directly, we had done the surface testing the day before, and then we got the surface tests on the same day we got the positive staff person's test result. And then we quickly rolled into 100% surveillance testing in the facility.
We absolutely see surface testing being a part of our future operations. And one of the big things that I appreciate about Enviral Tech is just the company being so open to where can we take it from here. And certainly it's great to have the ability to look for COVID. And we know that that's going to help us in this fight for the next number of months or however long we go through this. We're going to continue to use surface testing as a part of our day-to-day protocols.
Based on the study finding and the connection with our one facility that had an outbreak, We actually have taken it to all 24 facilities that we have, which includes 3 states. And so in the high contact areas, we're doing that weekly. And then the low prevalence, we're going to go every other week. So we just started that last week. It took it to a different level for us as just one more level that we can do to make sure that we can quickly identify and track any COVID in the facilities. And so we are fully in. So.
And then I have just one more slide. So the conclusions from the study is that we determined that surface testing is a cost-effective supplement to human testing to help save lives in senior care communities. In fact, we think it's reasonable to conclude that the study itself, just these tests that we did in the course of the study, probably saved several lives because of the contribution to early warning. The study data show that with 4 swabs, you could expect somewhere around a 70% sensitivity. That means that if you had an outbreak in a facility, you'd have a 70% chance of seeing it. And with 8 surfaces swabbed, you'd have a 90% sensitivity. We found that the chairs, carts, and faucets appeared to present virus more often than other surfaces. And we have, of course, information about a wide variety of others. And I know we didn't leave very much time for questions, but I want to quickly hand it back to Johan to see if there are any questions that we could answer quickly.
Thank you, Steve. That'll be actually for Jennifer. Jennifer, do we have any questions in the chat room that we need to answer?
Yes, I do have one question. Again, if you do have questions, type them in that Q&A box and we'll get those addressed for you. So based on tested facilities, are there any specific symptom types or configurations that aligned with lower test rates? Thinking UFAD, displacement, ventilation configurations.
So I'll take that question. We did not have information about the practice of medicine inside the facilities. We did not get, we did not want to receive any clinical information for privacy purposes, so we don't have those data. We do know, however, because we gathered information about whether people were asymptomatic or symptomatic, and it appears that asymptomatic people shed at a lower level. I don't know, we haven't determined whether that's statistically significant at this point, but our experience was that asymptomatic carriers have a lower level of viral shedding.
Okay, and then HVAC system types?
Again, we did not correlate any information that in the follow-up before we published this. We're going to continue to gather data, but at this time, we have not done any correlations with the HVAC system type.
Great. Is this program you sign up for, or do you pay individual test?
We have a couple of different models. You can do a one-off where you would buy just one kit and have it tested. And we also offer subscription rates that provide a little bit of a discount. For the purposes of the study, we did a cost share where the facilities paid a portion of the cost of the testing, and then a big part of the test was subsidized for the purpose of the study. But as you heard, both of those two clinical coordinators indicated that they are moving into a paid subscription for all of their facilities because of the positive experience that they had with the study.
Great, thank you. How quickly can you respond to requests for supplying tests?
We can usually turn a supply of kits within 24 hours. And something that I forgot to mention during the study is that we provided feedback on the tests. More than 99% of the time, the results came back within 24 hours of our receipt in our lab. And in most of the cases, that meant within 24 hours of the swab actually being taken in the facility.
Great, thank you. And that's all the questions that we have for now. So I want to thank you, Steve, Kevin, Yohan, and Phil for today's webinar. And thank you everyone for joining us today, and Tech for sponsoring. And is there anything you'd like to add?
Thank you very much for the opportunity. It's been a great pleasure, and we're committed to helping save lives through testing. We have to do something to help those that are most at risk in this time.
Thanks, everybody.
Great. Well, that concludes our webinar. Thank you so much, you guys. Have a great day.